And when we're talking with people about these problem areas, ideally what we're doing is trying to sort of change this stream and change this. So if they're not binge eating, then maybe it doesn't cycle back up. And if they're simultaneously working on improving their relationships, then maybe their self-esteem is starting to go up. And if their self-esteem and mood are starting to go up, maybe they feel the urge, the compulsion to binge eat again, and so forth. Does that make sense to you guys? It's a little bit of a complex model, yeah.
I was curious when you talk about cultural values regarding eating and shape and weight. You have experience with adolescents or adults who learn a certain set of ideas and thoughts and beliefs around the culture within their family, and when that differs from the culture, American culture, and traditional Western culture. I'm thinking about the first generation, second generation families.
Absolutely. So I have two thoughts with that, and please chime in if you do. One is, when you said that, this quote that a client said to me, she said, food has been weaponized my entire life. So like in microculture, her family, she had probably a great-great-grandmother with an eating disorder, which sort of got passed down the generations, and they, like the whole lock on the fridge thing, the whole thing. So that's a like micro example. That's certainly a more extreme version of what we're talking about culturally. On the other side, I've worked with families of different ethnicities, different races, where the body ideal isn't necessarily super thin. So there's not pressure in the other direction, but different expectations of what it's like to use food, and how food is part of celebration, and how binge eating is sort of a thing, right? Like people maybe don't experience loss of control, but certainly have times when they way overeat, and it's a total cultural norm. Experiences where if you lose weight, that's considered odd or unusual, or are you sick? In gay male culture, for example, when I worked with various clients, one client I think articulated beautifully. He said, when I lose weight, people worry about me, right? And that comes straight out of HIV/AIDS, where weight loss was a sign that you were ill. So I think you have to sort of be aware of those micro examples, of course, in the greater context, and not assume that everyone is experiencing it the same way. But also, I think it is pretty global in terms of the United States.
I feel like a lot of the adolescents that we see on our teams that are from racial, ethnic, minority backgrounds, there's a lot of mixed messages. Like the message is almost, there's a perfect place for your body to be, and you are never there. If you're too thin, there's a lot of criticism. Oh, you need to eat and gain weight. But as soon as you start you're gaining too much weight, yes, and you need to go back. So it's almost like they're like set up for never being okay where they are.
Yes, and I think the medical community doesn't help that either.
Yep.
Right. So
there's such a narrow range.
There is a narrow window, and if you're off the band, yeah, off the trajectory in one direction or another, I think even well-meaning parents get nervous. And certainly pediatricians aren't always trained in effective communication, either are adult doctors for that matter, in terms of how you communicate with people about weight effectively. And so that's just reinforcing. Yeah.
I'm just thinking about the gay males and the wasting disease, and how that translates or moved into exercising and being buffed and so on, and presumably, I'm guessing, more sort of disorders of, what's the word for it, is it orthorexia, is it, what's it called?
Yeah, I know exactly. Yeah, sort of hyper-focus on eating, and eating only nutritious food.
Right, and then the context there is so complex.
Indeed.
Yeah. So do they fit this model? Does that?
So, I mean, I think we could say that that's an extreme weight control behavior, potentially, even if they're eating nothing but healthy foods, because of the sort of obsessiveness around it. And from an IPT perspective, what we would be looking at is really trying to understand what is the interpersonal context within which this is derived. So, did the person develop this because his or her partner, you know, wants a certain body type? Did it occur because, you know, they moved cities and suddenly sort of felt like, oh, exposed or too out there? There's all sorts of, so we would be really focused on the interpersonal triggers that are maintaining this and interpersonal maintaining factors, not necessarily like, why did this initially start years ago when you were first binging and now you're doing this? And so we'd be understanding that in context, but really here and now, what are the interpersonal situations we need to be working on?
Yeah, so it would fit with this model.
If, I don't know if I'm a carpenter and I have a hammer, that looks like a nail to me.
Yeah, yeah.
So if you had a client who was triggered to binge eat from social anxiety, what would you do with that trigger?
That's a great question. So the question was, if you have a client that's triggered to binge eat by social anxiety, I would say that's 50% of my caseload. So we're going to go through very specific, and I'm going to give examples of that, but in a nutshell, we might conceptualize it as an interpersonal deficit, that the social anxiety has sort of created a paucity of closeness because people are afraid of interacting with other people. In that case, depending on the severity, we might consult with a psychiatrist and work on medication management so that they can actually sort of get over the hump of actually using some of the IPT tools. We might refer to CBT first for basic, you know, social anxiety treatment, and then come back and work on the binge eating after. Sort of depends on the case example. Yeah. You speak up.
Somebody struggling with eating but not necessarily feeling significant. So I try to, and as the conversations go around societal cultures, norms, everything like that, those conversations will come up daily, right? In all of our offices, even those of us that don't specialize in eating disorders. And I try to come from like a health at every size, intuitive eating, like mindful approach. But I have seen the shame, I've seen the same cycle happen with inclusivity and empathy from almost that health at every size perspective. By kind of saying, well, I want to lose weight. This is something, this is my core desire is to lose weight. And it might not be at that level of disorder eating. And how to approach that without being ashamed, but still honoring their desire to lose weight. I don't know if I'm speaking to that, but it kind of follows the same.
I think what you're asking, and correct me if I'm wrong, is that there's a difference between the health at every size approach and the weight management approach.
Yes.
And sometimes the health at every size approach shames people who want to lose weight.
Yes, change the diet or like
Yes.
diet right after this.
Yes. So as a person who's worked in obesity treatment, I have been attacked on multiple occasions by people who think that even discussion of weight loss is biased toward people who live in large bodies. And that's really complicated for me, and I've done a lot of crying and peer consultation about that. Because I would say that I generally actually come from a health at every size perspective, meaning I am not in the world of trying to get people to lose a lot of weight quickly, but honoring a person's individual desire, as long as what we're actually honoring is the person's desire and not some sort of like parental acceptance issue, right, where the person can only feel accepted by their parent if they've lost weight. Like then that to me is the area of treatment, right? Self-acceptance first maybe. And then a discussion of, do you actually want to do weight management for you? Or is it, so I try to make that distinction. It's an ugly world out there. So yeah, I don't know, does anybody else know, do you guys know what health at every size is? No? Okay, so someone else would like to talk. Who else knows about health at every size and wants to talk about it?
I can say
Yeah,
something,
please.
but it's basically this movement where the idea is that no matter what your weight status is, you can be healthy there, and accepting that there's a spectrum of body shapes and sizes. There's a narrow range of what's accepted in our society, but if you live in a larger body, that you can be healthy even in that larger body, and kind of helping people to accept that even if they're outside the norm of what's accepted in their culture, that they're still okay where they are.
And then some people take that mentality and sort of take it to an extreme level.
Like you can never lose weight, or you should never focus on weight loss as a goal.
Ever.
Which I think is discrepant from the idea of health at every size, because some people aren't healthy at the weight that they're at, and losing weight would help them, but that doesn't need to mean developing restrictive and extreme eating
Completely
behaviors. So.
agree. Yeah. So yeah, if you get interested in the world of eating disorders, you're definitely going to run into the health and the HAES stuff. So the first time I was ever attacked, I went to my peer group, and who are more experienced than me by a decade or two, and they were like, "Oh, you got hazed." I was like, "Oh, okay, that feels so much better. There's a name for that." Whew, okay, and it's not meant to disrespect people who believe and practice the HAES thing. It's just that, like anything, there's people that take what you're doing and sort of take an extreme view of it. So I guess that's my long answer to that question. Okay, let's teach you something. So I put this up here in case you're a person who prefers to read instead of look at the model. So according to the model, negative feedback regarding an individual's social worth triggers eating disorder symptoms via its detrimental effect on self-esteem and associated affect. Engagement in eating disorder behavior is a response to negative social evaluation that is in turn intensified as a result of the eating disorder, that recycling loop that I showed. And in the context of worsening social evaluation, eating disorder behaviors may be perceived by the individual to be a more reliable source of esteem and affect regulation than that is provided by their social world and their social interactions. So therefore, the eating disordered behaviors, for example, binge eating, comes to increasingly sort of override or supplant constructive attempts at engagement in the social world. So I feel down, I feel bad, what do I do? Instead of reaching out to my peers or friends or colleagues or whatever, if I'm constantly getting negative social evaluation from them, I use food to cope. And over time, food becomes my support around that, right? Because these are not working for me, so I turn here. And so that over time becomes sort of even more powerful and starts to replace social interaction. And therefore, as a treatment, IPT aims to assist the patient in developing affirming relationships that provide a viable alternative to the eating disorder behavior in attainment of positive esteem and affect. So it's not like we're trying to force them to stop binging. We're trying to give them another place to feel validated, to feel esteem, to get affect regulation, support to develop coping, so that they have to use food less. You guys have the DSM, you don't need to look at this, but I just wanted to put it in your slides just as a sort of reminder, because IPT is evidence-based for binge eating disorder, which is finally in the DSM, as not just a research criteria, and bulimia nervosa. Very briefly, I have some of these studies up here in a folder if you want to look at them in your lunch break. You could do a lit search yourself. I'd much rather spend our time talking about the clinical utility, but just briefly, CBT and IPT are often sort of pitted against one another or looked at simultaneously to see if one is better than the other, or is IPT as effective because CBT has a better, longer track record, if you will, in literature. And so essentially what we know is that for bulimia nervosa, post-treatment recovery, and I think in this case it was like immediately after the 20 sessions or something, CBT had outperformed IPT. But when we look at follow-up at a year later, the two had basically no significant differences. So, and that has been borne out again and again in the literature, which suggests that there is a slower time course in IPT, which makes total sense, right? We're going after the big picture interpersonal things, not the eating disordered cognitions. So there's a slower time course, but it's equally effective. So you should talk to clients about that, right? Someone with anorexia nervosa who's medically very risky or very sick, you know, there's not a lot of evidence to say that IPT is the route you should take, because obviously medical management is a priority and we need something that's kind of quicker. So right now, IPT is the only psychological treatment for bulimia nervosa that has demonstrated long-term effects equivalent to CBT. IPT for group, so this willfully is the person who's primarily been sort of active in developing group treatments for binge eating disorder. And in a nutshell, basically, we discover that the same sort of thing, a little bit slower post-treatment, a little bit lower post-treatment recovery rates for people in IPT, but that at longer-term follow-up, that IPT is equivalent to CBT, and that those effects are sustained at even lower post-treatment. Hilbert and colleagues in 2012 wanted to extend Wolfley's original study using IPT for group, and again showed that there were actually higher rates of long-term recovery rate for IPT versus CBT, and that the treatments really sort of didn't differ over time. So this is the one study that has highlighted that maybe the time course isn't that different, and they said methodologically what happened was in this study that they had done a really careful job of making sure that they kept the linking of interpersonal work to the eating disorder symptoms. That the more you link for the patient in the sessions with you, that maybe that closes the time gap a little bit. So in CBT for eating disorders, you're talking explicitly about the eating disorder. In IPT for eating disorders, you're less talking explicitly about the eating disorder and more about the relationships. But if you keep linking those two in session, then it might slow the time gap. Okay.
I feel like with IPT, it's also a little bit easier for patients to kind of generalize the interventions to other areas of their life. So CBT is like so specific that it's hard to like go from like changing your thoughts about your eating to like using those same techniques with other areas. So I kind of wonder if there's more of a generalized effect of IPT, which then further improves the binge eating over the long term.
I can only imagine that that's true.
I don't know if anyone's looked at that, but
I see it happening in my office.
Yeah.
You know what I mean? Once you learn how to communicate differently, that shows up across the
you're
board.
less depressed and less anxious.
Yeah, it's shocking, right? And then, of course, people start getting more and more positive feedback from other people, and then start branching out. Maybe they start dating, or maybe they start joining a community group or a club or something, and so they're just spirals. Yeah. So anorexia nervosa, initially, back in 2005, it looked like IPT was not very effective for treating acute anorexia nervosa, and basically people in this case had performed best with non-specific clinical management. So that was pretty preliminary, and it was a small sample. Now there's some longer-term data that looks at a mean of 7 years of follow-up post-study that revealed about 50% of patients received a good outcome, but it was sort of across the board. There wasn't one treatment outcome that seemed better, or treatment modality that seemed better, so CBT or IPT or this clinical management. So in a nutshell, I don't really know. What I will say is that in practice, because I treat primarily the binge eating and that side of the house, I don't use IPT for people with anorexia nervosa. I don't know many people that use it in the acute treatment of anorexia, probably because of the intensity of the medical management that's required and the safety piece. So I don't know if you guys have anything to add, please jump in along the way. But the evidence is, so in like summary book chapters, for example, about IPT for eating disorders, the conclusion is essentially, we still don't know. We're still really trying to learn how to use this, because with IPT, the mechanism of action is a little complicated. We're still learning that too. And so first we have to make sure that people are medically safe, of course, and that perhaps, like other disorders that we've talked about, we would address it with a more CBT or family-based approach first, and then later add IPT if there's things that are potential risk factors for re-triggering later on, those sorts of things. So this is sort of my selling point, even though I have no stake in you using IPT. I love it, and I think you will too. And here's why. I think your patients will. So we know that when patients have eating disorders, it's not uncommon. It's quite common, in fact, for them to express difficult social experiences. And we know that there are often problematic family histories, not always, but often problematic family histories, and specific interpersonal stressors. So in that context, it makes total sense that we would use a treatment that targets interpersonal relationships. And again, I think when you talk to people about it and they're able to see, oh, I didn't want to go to that Christmas party, so I stayed home and I ended up binge eating, they get it, right? They get that connection. And there's a lot of buy-in generally. We also know that people with bulimia nervosa and binge eating disorder do tend to experience a wide range of social problems like loneliness, lack of perceived social support, low self-esteem and social adjustment, and difficulty with social problem-solving skills. Whether that's a result of using food to cope at an early age, like in early adolescence, which is when often this starts to happen, and people never sort of learn how to navigate them differently without food, or whether that's a history of their family dynamics or whatever remains to be seen. But I think we know that there's a heightened response to these interpersonal triggers. And in fact, the interpersonal deficits problem area that we're going to talk about a little further, some people have suggested changing the name completely to interpersonal sensitivities, that people in that category tend to have a lot of responsive, sensitive reactions to even neutral feedback. So if they're not getting positive feedback, they perceive everything as neutral. So just, a person sitting there not nodding at me, I might perceive as, oh, you don't like this, as opposed to you're just listening.
Is there any correlation between attachment styles and the development of eating disorders?
Yes. So in the video that I'm going to show you about IPT for postpartum, I think, he actually gives a little graph that talks about different attachment styles, and particularly people that with anxious attachments, for example, are more likely to have these sorts of interpersonal relationships. We also know from my dissertation, among others, that interactive lab paradigms show that people who experience interpersonal distress tend to overeat, right? And that there are certain vulnerabilities of that, but certainly that is important for us to know. So then, in terms of relevancy and suitability, so IPT is manual-based, which means that, in theory, after this training, when you email Denise and say, I want your manual, please, in theory, you could go do it, right? I mean, knowing yourself and knowing your clinical limitations, I trust you all to be competent clinicians, that because you have a guideline and you really know some tools and skills, that you should get some supervision around it, but that you can do it, which is really important, because if there's not a lot of people in Rhode Island doing this, then good for you for being here and learning. And we know that because it directly targets the interpersonal and emotional problems that are involved, it's often really well accepted by patients. So when we've asked clients in research studies, these are the two treatment options, IPT and CBT, and we explain the models and so forth. In general, people rate them as like having high expectations for the treatment to be effective, based on just understanding what the treatment is, which suggests that there's some patient buy-in, like they get this model intuitively. It may be particularly useful for people that are sort of difficult to engage clients. And why that is because if you're talking about difficulty in relationships, you're experiencing it right there, and that person has experienced it outside of your therapy. And so if you can, with good clinical judgment, talk about that, right? People feel excited, like, oh, I might actually be able to take this and use it, again, apply it to other parts of my life and actually see improvements. It's also really well accepted by clinicians, generally speaking. So when you leave here today, I hope you'll think, I can do that. Like, that makes sense to me, and I feel like I have a toolkit for doing that. And it seems intuitive in some ways because we do talk about relationships already in therapy. I do understand how when mom says this, that makes my patient feel Y, and maybe we can use some role playing and other things, some tools from IPT to help improve that. There are also several comprehensive clinicians guides, so I brought a couple of them here today. So this is the Bible, this is Myrna Weiss's newest textbook, the Guide to Interpersonal Psychotherapy. And it has, like, session by session, has a chapter on eating disorders, but it really goes through step by step. So there's that. From the IPT Institute, so IPT is sort of worldwide, and they've developed little things like this little flip chart thing that you could go through and look at, you know, oh, here's like an interpersonal formulation example. So you have to buy this. You have to buy the thing. And then this is Denise Wilkley's book on IPT for group. And so if you're someone who's interested in using this in a group format, which I highly recommend, it's so exciting, and I'm really not being nerdy, it's really exciting, then I highly recommend buying this again, because she talks through really important tools and strategies, and you can, talks about the problem areas in detail. So I brought those just in case you want to peruse them. Okay, so we're going to do the phases and techniques. Maybe we'll take a break in like 15 minutes, just a 5-minute quick rest stop. Does that sound good? So the treatment structure is typically between 16 and 20 sessions, usually done over a 4 to 5 month period, and that includes those full 3 phases. The fourth phase, again, is maintenance, and you have to recontract for that, so we'll talk about what that means. So the initial phase is focused on identifying the problem area that will be the target for treatment. So it's an intake. What's going on with this person sitting in front of me? How do I conceptualize it, given the IPT framework of it's likely one of these 4, possibly 5 problem areas? Which one seems most relevant? And that's going to then guide the rest of our treatment. The intermediate phase is the actual work. So it's the time when, once you've identified problem, then you use several sessions to actually do the work in helping the patient make progress in their identified goal area. And then the termination phase is actually several sessions where we work on consolidating the gains, really doing a lot of that positive reinforcement, a lot of you got this, like this is going well, linking, showing notice how this relationship has started to improve and how much less triggered you feel to binge eat, for example. When you got that invitation to the, office Christmas party, you actually went, and yes, you felt a little uncomfortable, but boy, you had a plan and you handled it differently. So a lot of reinforcement and a lot of talking about how the ending of therapy in and of itself can be a trigger. So we'll talk through that. And then maintenance, which is termed a continuation phase or a maintenance treatment, is a separate contract. So in your handouts, I copied out of the Weissman book for you, just it's at the back of the handouts, I think. Just a 3-page table. That's a basic outline of IPT. Now this is general IPT, so IPT for depression, but again, the tools are transdiagnostic, so these are certainly tools that are applicable to the eating disorder. You would just specify them for the eating disorder. But this table is a really nice outline, so look at it on your own time, but I wanted to provide it without having to go buy the whole book. Okay. So let's dig into the first phase. So the first phase typically occupies the first 3 to 5 sessions, and the first aim is to basically make a diagnosis. Describe the various treatment options. So for example, this is what IPT is, this is what CBT is, and sort of give a hypothesis about what you think, why you think this might be effective for the person. Provide psychoeducation on the disorder, consider the medication, and then engage the patient in therapy. So if you decide to do IPT with a client that they have collaboratively agreed with you that, yes, I think this could help me, I see how this might be related, and I'm willing to do some work in it. The second aim of the initial phase is to describe the rationale and nature of the treatment. So again, more about psychoeducation, but not about the diagnosis, about the treatment. So why do we think this treatment will work for you? That the fact that it's evidence-based, and maybe you have to explain what that means to people, right? Because not everybody out there is in the literature. So talking to patients about how important it is, that there's some evidence behind what you're doing and that it has been shown to be effective, that can really bolster people's sense of confidence both in you and in the treatment. The third aim of that initial phase, so again, those first sort of intake session phases, is to provide support, encouragement, and help the patient feel understood by identifying and normalizing. So this is the time, in my mind, where therapeutic alliance comes first. You have to let the patient know that you understand what they're experiencing by listening. And that's not manualized, that's good clinical practice, and you, I'm assuming, already do that. But listening through an IPT ear is a little bit different than listening through a different ear. So really trying to listen from the perspective of what are the relationships, what's going on, and then validating like that's really hard, that's really challenging. And then the final aim is to collaboratively with your patient, identify and agree upon the current interpersonal problem area, so one of those 5 problem areas